to talk primarily ovary and endometrial cancer. I'll touch a little bit on cervix cancer, but the biggest one that a lot of people talk about is ovary cancer. Even though endometrial is much more common, ovary cancer is sort of the silent killer. It's the one that has the highest mortality. It is not that common of a cancer. The overall risk for an average woman is about 1.3%. But as a referral center, we see a lot of it, and it looks very common. But there are a lot of women going to GYNs every day. And so the hardest part about it is there's really no way to accurately screen for it. One of the reasons we may not really develop a great screening tool is it has to be common enough to have reliable markers and that sort of thing that are associated with it. There are certainly several risk factors. Essentially, the way we look at it is the more time a woman is ovulating, there are more injuries to the epithelial layer. You have follicles and cysts that rupture and form. And so the earlier you go through puberty and the later through menopause, if you haven't had kids, haven't interrupted that cycle, there are more injuries to the epithelium, which is the most common type. And so there are risks for DNA errors and that sort of thing with the cells to replicate in such a fashion that it develops into a cancer. Alternatively, if you're taking birth control pills, if you've had children, later puberty, earlier menopause are all things that are going to protect women against it. Birth control pills are actually incredibly protective. 10 plus years can reduce your risk by 50% over your lifetime. So it is a very helpful tool to have. So the things that we're looking for are regular, consistent bloating, nausea, vomiting, pain, distension, diarrhea, constipation. If these type symptoms are persisting for 10 or 14 days in a row, you've tried some over-the-counter medicines and nothing is getting better, those are reasons to go and look and have somebody sort of investigate. And so it is really a symptom awareness thing. And unfortunately, average age is around the time of menopause, and women have a lot of those symptoms and don't know, is it today or tomorrow, if it comes and goes. And so by the time it is persistent, a lot of times when it is a cancer, we've sort of kind of caught it a little bit later because of those symptoms. Ovary cancer spreads throughout the abdomen and the pelvis, and so those symptoms develop, and then we end up catching it on average at stage 3C. So that's out of 4B, so a more advanced stage process, which is one of the reasons it's harder to treat in the long run. That being said, about 75% of the time we catch women that advanced, we can still get them into remission. More oftentimes than not, it will come back, but we still have a very good fighting chance. At this point in time, we traditionally use surgery and chemotherapy still. The goal in seeing our patients up front is trying to decide when surgery is the right time. We either try to operate up front, resect everything, and then do chemotherapy afterwards, or if we don't think we can get everything with the initial surgery, we will do chemotherapy up front, split it in half up front, surgery, and then chemotherapy afterwards. And so with that sort of neoadjuvant chemotherapy, we are able to increase the rate of getting everything at the time of surgery, and morbidity associated with surgery is a lot lower. So a couple different options on how to play that game. What's changed even in my time since being a resident and fellow is some of the newer drugs and different things that are available for some of the harder to treat cancers. Not only do we have the traditional cytotoxic chemotherapies, we have biologics, so monoclonal antibodies that are targeting new blood vessel growth. Tumors like blood vessels, they like nutrients, and so they are constantly building new vascular networks. And so there are certain medicines that block those growths. We can use them in the upfront setting, we can use them in the recurrent setting, we can use those when we get some type of resistance to the other chemotherapy, so we have those medicines available. We have there are some oral medicines that we use as maintenance therapies for people that have different genetic mutations, and we'll talk about genetics as well. But there are oral therapies that are significantly prolonging survival in patients, twice as long as patients that don't have them or don't take them and have those same mutations. So that's a newer thing that we have available. And then we have a newer class of drug. It's called an antibody drug conjugate, and that's essentially an antibody that has a chemo drug attached to it so that it can find the cancer better, and they're able to deliver more targeted therapies directly to those patients that have different receptors or mutations present. I'd say probably the biggest difference with ovary cancer now is the amount of genetic testing we're doing, which is also a way we can help screen and prevent people from getting these types of ovary, fallopian tube, peritoneal cancer, essentially the same entity. But we are doing a lot of genetic testing. Everyone that gets ovary cancer now gets germline or DNA testing to know if there is a mutation in the family. As far as endometrial cancer goes, a lot more common. I'd say 3 to 4% lifetime risk. It's the fourth most common cancer in this country now. I think it's breast, colon, I can't remember the third, maybe wrong, but fourth most common. The biggest risk factor for endometrial cancer is obesity. So the physiology behind it is there's an enzyme in the fatty tissues called aromatase that converts other hormones into estrogens, and the more estrogen you have for the longer period of time you have, it stimulates the lining of the endometrium to grow and develop cancers. And so that's why we see more of it. Obesity is bigger in this country, but that's the biggest risk factor. Fortunately, it has a symptom, bleeding. Postmenopausal bleeding, abnormal bleeding. Women have normal cycles, it starts getting heavier or irregular in between cycles, and certainly anybody with postmenopausal bleeding needs to be seen as soon as possible to rule that out. It's not the number one cause of postmenopausal bleeding, but it is what we need to rule out. Because of the screening, we're able to catch, or because of the symptom, we're able to catch it early. So 75% of the time in this country, a woman is diagnosed with uterine cancer. It is stage 1. So we catch this much earlier than stage 3 ovary cancers. We are also able to treat this primarily surgically. Because we catch it earlier, it's confined to the uterus, we can do minimally invasive surgery. We do not do open surgery very often anymore. I'd say 95% of our patients go home on the same day, no matter what we do laparoscopically now, so recovery time is significantly improved. But like I said, 75% of the time it's caught within the uterus, and most of those women are cured with surgery. Occasionally we need some lower risk radiation, basically inside of the vagina, at the top of the vagina, or more rarely is actually chemotherapy for it. But we like those patients, we can catch them, we can treat them, and they have really good outcomes. As far as where endometrial cancer is, a lot of the stuff is focused is on the advanced stage disease and the recurrence, because it is harder to treat. We don't have as many approved drugs like ovarian cancer, and so we still traditionally use chemotherapy, but also radiation. We have some newer studies both here in the US and in Europe that show using a combination of chemotherapy and radiation are more effective for stage 3 and 4. And then lastly, a little bit on cervix cancer, not a whole lot, but this is like one of the few cancers we can prevent. We have a vaccine to prevent this, and unfortunately it got branded as a, like an STD type of vaccine or a sexually transmitted disease. And while it is, we have totally changed how we present this to the public to say this is a cancer prevention vaccine. This is an HPV cancer prevention. A lot more than just cervix, vulvar, vaginal, anal. A lot of the oral head and neck stuff is way more prominent than even any of the GYN stuff now. And so we've tried to rebrand it in such a way that it is more acceptable to the public as far as the Gardasil vaccine goes. What I have been trying to, and a lot of us have been trying to push, is increasing our vaccination rates. The South is terrible compared to the rest of the country, but we are now above 50%, at least in Tennessee. And so we are continuing to push, whether that's in the pediatrician's office or in the dentist's office. The oral, we have the oral cancer screening grounds. And so if we can catch them there, it's anywhere that we can catch people. It was not approved for people up to 45 when I finished fellowship. When I got here, I got the vaccine because I think it's safe and it's good. And so you can get it up to age 45 now. We are just now starting to see the true effects of the vaccine on a population-based level. And most of this stuff comes from Europe and Australia, where they have, countrywide vaccination programs. In Australia, they've essentially eliminated genital warts because of the vaccine. And then the latest thing I saw was a study published from the UK that looked at their group of women and kids that got the vaccine series, early teens, 11 to 12, had an 80% reduction in the risk of cervical cancer. So that is profoundly impactful, and so I can't stress enough getting everyone you know that is in that 9 to 45 age range vaccinated. It is still safe. If we can push that, it will make a huge difference. And we have a reliable screening tool for cervical cancer. Pap smears has been sort of the gold standard. In this country, most of the people that get cervical cancer don't go to the physician, they don't get screened, they don't get pap smears. And so we've actually switched more to trying to push primary HPV screening, so essentially a swab to look for the actual virus that's responsible for it. Provides a lot more reliability over a 5-year time period to say if you are negative, the chance of you developing a pre-cancer in the next 5 years is like less than 1%. So for people that don't come to the doctor regularly, which doesn't necessarily apply to everybody, but those patients, if we can use HPV screening, we can say, all right, if I don't see you for 4 years, I feel a lot more, I feel a lot better about your chances of being fine. So screening is reliable for cervical cancer, and we have a vaccine to prevent. Fortunately, endometrial cancer we can catch early, and most people are treated with surgery alone. And then ovarian cancer, just listen to your symptoms in your body, and you know what's off, and you know what's different, and don't let somebody tell you it's nothing. Just keep pushing until you find somebody that does some more evaluation.
Awesome.
Okay?
Thank you.
That's what I got.